So I'm just going to keep on going through this. So the problem is the U.S. Healthcare system is volume driven and it's not quality bind. We only have a finite number of resources. And as I just showed you, the care is all over the place on how you treat people. Now, lumbar fusions is one microcosm of indicative to all of healthcare. There's no definition of indications. And interesting, I tried to go out and find evidence-based guidelines for lumbar fusion, and I couldn't really find them. And I'll go through that because you could find specific points, but you couldn't find a overriding fusion guideline. So we made this basically algorithm. What we did is we set up two different pathways. One was for education, and the other one was to try to get better outcomes for my department and to find what indications are. And I'm going to go through that. And I'm going to go through this really, really quickly because if you're familiar with the quality-based quality improvement measures and algorithms, I'm going to show you a couple of tools that are great to help. And one of the things is they call a threat and opportunity matrix. And it's very simple. You look at what are the opportunities if I do this versus if I don't do that, short-term, long-term. And it helps understand why you're doing this and who is it going to benefit. And so the second thing is, and so you can do that, and you should do it pretty much for all your projects because it helps you when you have to present these out to patients, to a committee. The second thing that's kind of another great thing to do is called the stakeholder analysis. And why it's important is it really starts putting out in your mind, okay, who's going to be influenced by this, number one. And number two, are they going to be helpful and how helpful? And the second thing you want to understand is, are these people going to be against my project? Because those are the patients you need to convince the most to get onto your team and get along with the project. And so you need to devote some considerable effort to pushing your project along. And again, other people that we have, and for us, the nurses were unbelievably supportive for this. IT team really had no interest in helping us, but would do it since we got our bosses and our sponsors. So we built and if you're looking for a book, another really good a book that really talks about building things and moving forward is Cotter's Creating a Guiding Coalition. And it really talks about how you get people motivated and how you push forward. So what I did is I built a grading sheet for every patient. And then I used the NAS appropriate coverage position, which is the best evidence-based policy you have when you're looking at lumbar fusions. We went through, and then there was 9 different areas where we talked that patients had indications for a fusion. Now it's kind of interesting because when you look at some of the data for it, some of it wasn't great, but it was the best data available. And again, that's what guidelines are. They're trying to give you the best data, best evidence to make some decisions. So went through it, and then I had to say, okay, how am I going to measure this? And this is a validated study. It's called the Oswestry Disability Index. Very simple tool. It's actually great if you've never heard of it. It's 10 questions. It takes the patients about 3 minutes to fill out. And essentially, it rates everyone between 0 and 5 for the 10 questions. And so you get a score. You want to have a score of 0 because what it represents is what percent disabled you are. So you get the 50 points, you multiply it by 2, and that's your percent disability. So if your score is 20, that means you're 40% disabled. And this has been validated in multiple different ways. And so when you look at the ODI for our patients, typically you're talking in the area of about 20 to 35 in general. In order to get them better, remember we talked about the MCID is the minimally clinical important difference to improve patients. You need to drop them by 5 points. And if you want to make them, if you really are doing great, you want to improve them by 10 points. And so these are the things when we set up, we said, okay, how do we do and what do we do? So then we made an algorithm. I'm going to skip through this really quickly. Is basically you went through, we measured their scores, we followed them. The one thing I did do is preoperatively before any surgeries, and I actually still do this today because I thought it was such a great tool with the residents and medical students, is every Monday I sit down with every case for a lumbar fusion at Jefferson for the ensuing week. And we go through with the residents and we say, okay, does this meet the evidence-based guidelines? Does this not meet the evidence-based guideline? And we discuss it, and hopefully, hopefully we're not having many that don't. But again, guidelines are guidelines, and they're only there to help you. And so we went through, and then we followed their outcomes up for 12 months. And what we found is, here's a patient that 60, I'm going to give you a couple of really quick examples. 69-year-old lady came in with bilateral leg pain. She had a grade 2 degenerative spondylolisthesis with severe stenosis, underwent a L4-5 transfemoral body fusion. And we didn't really concentrate, we didn't really focus on what operation they got, should they have gotten interbody fusion or anything of that sort. And we're going to go back, and I'm going to talk about that in 1 second. But we looked at this case. So as you look, it's one of the 9 indications is for deformity in terms of degenerative spondylolisthesis is an indication to operation. So it's an evidence-based medicine concordant operation or an indicated fusion. And this patient did quite well. Her ODI went from 16 to 2 at 6 months. Next patient, and here's a patient that didn't do as well. A 57-year-old man with neurogenic claudication. He had exhausted all his operative treatments, underwent a 5-level lumbar fusion, really did not have a deformity, did have a lot of stenosis, but unfortunately this patient did not meet the guidelines and actually did not do very well and actually got 2 points worse at 6 months with his ODI. So then, we went and we looked at historic outcomes, and I'll skip through this really quickly. But what we did by setting up this algorithm, our ability to collect outcomes on our patients, we went up from 28% before we started the project to 100% collection of ODIs for all these patients. After 6 months, we actually had about 325 patients in our database with 6 months follow-up. 5% were lost to follow-up, which is actually pretty good when you're doing these patients. So what happened and what were the results? So if you looked at, we looked at these people at 6 months, and this is, you got to take into a grain of salt that some of the patients, have other issues. It's an elderly population. So if your patient does fantastic and then has a bad hip and they get weakness and disability because their hips are bothering them at 6 months' time, it doesn't matter. Your ODO guy goes down. And so your surgery might have been great. We are following just a general outcome metric. So that's one criticism. But with that said, if you look at the whole group, almost 80% of patients improved. 12 patients, about 4 or 5 patients, about 4 to 5% with no change, and 16% did decline. And so when you looked at the patients, you'd say, "Oh, that's not that great about decline," and we'll go through that in 1 second. But as you went through this, almost half of the patients actually got better and had a substantial improvement, what we talked about, as opposed to the patients that declined. Most of them who declined pretty much stayed around where they were before rather than drastically declined. So then we went through and we said, okay, now let's figure out what's going on, what happened, and how to hang. We looked at the indications. Remember, I said there was 9 different reasons for it. So if you look here, we broke them down a little bit more from the 9 major reasons. But these were the different indications. And then we looked at of all the indications versus a patient's being evidence-based concordant or evidence-based discordant. Only 7% of the patients were defined as evidence-based discordant.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.